Good day everyone. Welcome to our case study presentation on abnormal blood cell morphology analysis. This clinical case focuses on a patient named Mr. Amir Hassan. My name is Farah Fauzana and presenting with me today is my teammate Nurfitriah. We are both students from the Diploma in Medical Laboratory Technology program at Management and Science University. Let's begin with the patient profile. Mr. Amir Hassan is 52-year-old male who works as a construction worker. He presented with several primary complaints that have presented over the last 2 months, which is severe and presented fatigue, noticeable pallor, planar, frequent bruising. Additionally, he experiences unexplained with loss of 4 kg without any changes to his lifestyle or diet. His family history reveals that his father also has a known history of anemia.
Upon clinical examination, 3 key findings were noted that raised immediate diagnostic suspicion. First, pallor, which is the pale conjunctivate, were observed, which is classic sign indicating a significant reduction in hemoglobin. Second, splenomegaly, a mild enlargement of the spleen suggests that the body is working harder to clear out defective blood cells. And third is petechiae, small, spotted hemorrhages were found on his lower limbs, immediately raising suspicion of thrombocytopenia or low platelets. To confirm our suspicions, a complete blood count was performed. Here are Mr. Amir's key CBC parameters. Hemoglobin is critically low at 7.5 gram and confirming severe anemia. MCV is evaluated at 112, which points directly to macrocytosis, which is the enlarged red blood cells. The white blood cells count is slightly low at 3.5 times and indicating mild leukopenia. And for the platelet count is significantly reduced at 98 times, which is confirming thrombocytopenia. For the reticulocyte count is at 1.2%, represents an inadequate bone marrow response to the severe anemia.
We examined the peripheral blood smear to look closely at the cell morphology. Normally, erythrocytes are uniform, round, biconcave disc, measuring about 7 to 8 micrometers, standard pin with a clear central halo. However, Mr. Amir's red blood cells tell a different story. They are larger than normal, making them microcytic. They are oval-shaped, called ovalocyte, and hyperchromic. We also noted a prominent variation in their size and shape, alongside the presence of oval jelly bodies, which are nuclear remnants inside the red blood cell. To break down this cellular variation further, we look at 2 main terms, which is anisocytosis. This refers to a variation in red blood cell size. On Mr. Amir's smear, this is represented by the prominent microcyte. Second, polykilocytosis. This refers to a variation in red blood cell shape. In our patient case, we observed specific abnormal shapes like ovalocytes, and teardrop cells.
We also looked pattern in how the red blood cells arrangement themselves. For the Rolex formation happens when red blood cells stack like coins, typically caused by elevated plasma proteins. On the other hand, agglutination occurs when red blood cells clump together irregularly, usually driven by antibody-antigen reaction. In Mr. Amir's blood smear, we observed microless formation, which could suggest underlying protein or minor antibody interaction. The overall clinical and laboratory pictures points strongly toward vitamin B12 deficiency. However, if the patient does not respond to vitamin B12 therapy, further diagnostic investigations are required. These include measuring serum folate levels, performing an intrinsic factor antibody test, analyzing methylmalonic acid and homocysteine levels, or conducting a bone marrow aspiration and biopsy to rule out other causes of macrotic anemia. This case highlights the absolute importance of a peripheral blood smear examination. While automated analyzer give us raw numbers, the blood smear allows for direct visual observation, which detects precise morphology abnormalities and helps differentiate complex blood disorder.
Despite its clinical importance, identifying these morphology abnormalities can be challenging in a lab setting. Errors can arise from poor smear preparations, incorrect or inconsistent staining, or the presence of artifacts on the slide. Furthermore, many cell abnormalities look highly similar, which requires an experienced observer. This is all compounded by intense time constraints felt daily in busy diagnostic laboratories. In conclusion, examining the peripheral blood smear remains a crucial cornerstone for diagnosing hematological disorders. For Mr. Amir, the blood smear revealed macrotic red blood cell, hypersegmented neutrophils, whole jolly bodies, and basophil tripling, alongside a low platelet count.
Together, these exact findings confirm a definitive diagnosis of megaloblastic anemia caused by vitamin B12 deficiency. Following targeted treatment, both his laboratory parameters and his clinical symptoms improved significantly. Thank you for your time.